Just have to get into the camera view. Hi, I'm Caitlin. My paper. Oh. Okay, I'm going to be doing an assessment of the neurological system. So I'm just going to, for purposes of the video, go through it fairly quickly so I'm not taking everyone's time up. But I'll try to do it as how I would actually hopefully be able to do it. So I'm pretending that Jackie's here, or whoever is going to be my patient is right there. So the first and most important thing when it comes to evaluating the level, the neurological system, is to evaluate the level of consciousness. The level of consciousness is a really important tool in indicating how well the person's neurological system is functioning. So an acronym that we can use as nurses to kind of focus our assessment is AVPU, A-V-P-U, which stands for alert, question mark, verbal response, pain, are they in pain, are there signs of pain like grunting or moaning, and unresponsive is the fourth. AVPU, AVPU. So first thing we're going to do is assess the level of consciousness. It's the most important indicator, as I've mentioned. So when you're going in to greet your patient, that's the perfect time to do it, because you are going to have to be asking questions and introducing yourself, so you're going to be getting some response from them, hopefully. So you go in as you normally would. You might have your orders with you, or you might have some patient information with their name on it so that you can check with their patient tag. So, hello, my name is Caitlin, and I'm your student nurse. Today, I'm just wondering if I can get you to tell me your full name. So, blah, blah, blah. Okay, and I'm just going to have a look at your wristband if you can. So they're going to be able to hopefully lift their arm. If they're not, they were already having some indications of issues. So hopefully she's able to lift her arm and respond with her full name and her correct date of birth. Compare it, of course, to the chart. Make sure it's the right patient. So that's good. So I've assessed that she seems to be fully conscious. Making note again of how she's looking. Is she opening her eyes all the way? So level of conscious, this is part of this assessment. We're looking for how conscious she is, fully lethargic. Does she seem really drowsy? Obtunded, so is she having difficulty waking up? Stupor, is she completely out? Maybe some grunting noises, or coma, no response whatsoever. It's really important when we're documenting that we always write the patient response to our questions, to stimulus. So if she's not responsive to my questions, I may do a trapezius pinch to see if she's responsive to that, and I'll get into that in a few minutes. So this, again, really crucial that we put that into our documentation so that we're able to see exactly where they are with response and how it's changed over time. When we're doing a full neurological assessment, or even a focus, we're gonna be using a tool like the Glasgow Coma Scale. It's a rating tool, like from lower numbers to higher, and it gives us a number that would indicate where they are on the scale as far as being comatose or fully alert. So it's a really important tool, and it really depends on your place of work's policy, what tool that you'll be using for that scale, or that test, sorry. So if the patient is alert and they are responsive and they've orientated her to person as we have, we're also going to ask some further questions. So we want to be find out she's orientated to 3 dimensions. It's person, place, /location, and time. So we know from this patient she's orientated to time. So I'm going to ask her where she is, and even if it's just the city or if it's the location in the hospital, that's great. Time, it depends, again, if she has a clock in her room or a watch available. So, I mean, even if it's the day of the week, we can go from there. And next is language. So we've been talking with the patient, so we're already in the process of assessing her language. So we're looking for defects like dysarthria. So dysarthria is the defect in articulation. Before I go into that, it's just important to know prior to, from either patient's family or from talking with the patient prior, where she is with her speech abilities. If she has an accent, that's something we need to take into account, or if she has a hearing deficit, that can also affect it. So it may not always be specifically a neurological defect, it could be something else. So have an idea of that first. So again, as we're talking, we're listening to her, the way she articulates her words. We're listening for dysphonia, so that's abnormal sounds. Typically, this can be seen with somebody who's just had a stroke, or a seizure. They may not be able to actually use words and may verbalize and make noises in place of words. We're looking for aphasia, so that is the inability to understand written or spoken language. Again, seen very commonly with someone who's had a CVA. So she may not understand what I'm saying. She may, what she responds to me may not make any sense because she's not understanding. If I write something down, she won't be able to read it. So, and then we're also looking at agnosia, which is the inability to recognize symbols. You can test this by asking them to tell you what the shape of the paper is that you're holding for their response on that. Again, documenting everything. Next indicator are the pupils. The pupils are a huge tool when it comes to assessing the neurological system. Pinpoint pupil sizes are often an indicator of intracranial pressure. So it's really important when we're going through the full assessment that we're doing everything bilaterally, number one. But number two is when it comes to the pupils that we're really assessing the size and how accommodating they are to light. Are they dilating appropriately when it's darker out? Are they, can't remember the word, are they, my goodness, I can't remember the word. Anyways, are they changing appropriately? And so we've assessed this. We can use our tools like a pen light, an ophthalmoscope if we have that handy to do a further assessment. And then motor function. So as I mentioned, everything is going to be done bilaterally, and the reason for this, of course, is that the brain has the two hemispheres. The left hemisphere is in charge of everything that goes on the right side, and the right hemisphere on the left side. So it's really important as we go through the patient that everything we're looking at, we're comparing it to the other side so that we can notice that there is a change on one side compared to the other side. So motor function is really important, and when you're looking at motor function, we usually give it 5 points. Full motor function, so full range of motion, and full strength is 5 points. 4 points would be the full range of motion and less than normal strength. So again, knowing a baseline or if the patient is able to respond to you that this isn't normal for them is really important when you're doing this assessment. Number 3 points is they can raise an extremity, but not against resistance. So you can use your hand to provide the resistance. 2 points is they can move extremity but not lift it. 1 point is slight movements, and 0 is no movement at all. So that's another tool for assessing the neurological system. So it's also important when we're doing this assessment to try the arm drift or pronation. So what we can get the patient to do is raise their arms up bilaterally as far as they can, and we're monitoring for any turn inward, which would indicate that there's some sort of a weakness or that the limb has, or there's a neurological issue. So we're just monitoring that. That's a tool. Again, you can go through the whole head-to-toe assessment and go through each system, asking them to move parts of their body, doing full range of motion exercises with them, and then providing resistance to assess how strength is. So I can go through that too if I have to. If Jackie wants me to, I can do like the 2-finger, get them to pinch and try to pull. This one, the digits to the thumb is a good indicator of range of motion. Again, legs, lifting the legs up, knees upward, and then having them push the sole of their feet against me, having them raise their toes towards them. So, I have to look up what that's called again. So if the patient is completely unconscious, again, we'd be using the Glasgow Coma scale, and we may be testing things to try to rouse them. So for instance, we may be testing the olfactory, so their ability to smell. We could bring in something like coffee and hold it under their nose, or a noxious stimulant that's used at your place of work to try to rouse them. And then the trapezius muscles pinch is done up here. It's the muscle that runs horizontally above the shoulder blade, or bone, sorry. So you can pinch that, and you want to start off fairly gently and increasing over 10 seconds. Not extreme pain, but a little bit of pressure to assess if how alert they are, if they're going to wake up or not. Of course, we're going to do the vital signs. So I'm just reading this in the order she has. I don't know, I feel like I should have done vital signs pretty early on. But we're going to assess the vital signs for any changes that could indicate a problem with the neurological system, such as a high blood pressure. And we're going to do the sensory assessment. So we can start with the visual assessment using our fingers. Again, we've already checked the pupils, so we have an idea that they're responding or not responding appropriately. The visual, we'd start with their head here on either side. I'd move my fingers in the peripheral line of vision and then get them to tell me when they can see them. I get them to follow my finger just to see their eye and how it's moving. The optic nerve is moving. olfactory, the smell. So we're going to test that. Again, we can use like a common smell, have them block one nostril and smell through the other. A common thing is like cinnamon. Get them to identify that. Again, things like a cold can have an effect on that, so we have to be just conscious of that. Tactile, so we can use a cotton swab to see how they're feeling of the different sensations on their face, if they can feel it or not, if it's a soft sensation, if it's a rough sensation, getting them to label that. Auditory sensation, a way to test this is to whisper a word in their ear, like 99, really, really quietly, and ask the patient when they hear the word to say the word. So you would go on back and forth between both ears, different word, and you would whisper really quietly. When they heard it, they would say it, hopefully. If there's any concerns, you can also use the tuning fork. So you vibrate that by pinging on it, put it in the center of the head, and that vibration should be felt equally on either side. You can also connect it to the mastoid bone and get them to tell you when they stop feeling the ringing. It's a really good indicator of how their ears are working, and if one ear is hearing better than the other. Conductive hearing loss also, because it's touching the bone. It's different than when it's in the air, so they should be able to hear them both equally. And taste, so this one I'm kind of confused how Jackie wants me to assess their sense of taste. I mean, the patient can obviously tell you if they're not tasting stuff, so that would be a good clue. But I would assess their mouth by having them stick their tongue out and look at the back. You can actually check a gag reflex by using the tongue depressor, the very back of the mouth, to see if they have that reflex, which is an indicator of their nervous system working properly. You can check the tongue to make sure there's no atrophy or bumps or lumps, and they're able to actually stick it out properly when asked. And then we're going to assess the bowel and the bladder function. So this is found in the peripheral nervous system along the spinal column. We have the spinal nerves. So we're looking at S3 to 5 for bowel, and T9 to L2, and S2 to 4 for bladder. So I have a feeling Jackie's probably going to ask me to explain them a bit more, so I have to kind of brush up on that, but I know where they are located. I'm just not really sure what she might ask me about those yet. And lastly, so that's my head to toe. I mean, I'm not really sure what to expect if she wants me to actually go through each of these systems and do like the range of motions and do vitals. I'm not really sure. I just sort of read what she wrote and tried to go into a bit of explanation as though I'm teaching it to you guys. And then lastly, I'm doing how to react to an opioid overdose. So first things you're looking for the signs of an opioid overdose. So patient history, if you know that they've recently taken an opioid, say for instance, heroin, I mean, that would be a good indicator there could be an overdose. If you don't know, some of the signs that you're going to be looking for regardless are respiratory rates less than 12 breaths per minute, pinpoint pupils, so pupils that are extremely small. You want to, and another way to test this again would be to dim lights if you can, to see if they're going to dilate or not. If they're acting confused, if they're acting restless, really tired, they want to go to sleep, they're having a really difficult time staying awake. If the person is irritable, if they're going from two different extremes in mood, like for instance, extremely sad, extremely happy, if they're feeling desperate, like they have no hope in life and they're just maybe wanting to end life. And not knowing where they are is really important. If they're really confused, they can also be vomiting, have extreme nausea, uncontrolled vomiting. So it's really key to always know the opioid antidote. Naloxone is typically the correct one, as it expels the natural opioids and the synthetic opioids out of the opioid receptors and then blocks them from coming back in. Very key, especially because with an opioid overdose, you're usually seeing the really low resps, is to apply oxygen right away and then immediately notify the prescriber as well as your charge nurse. So that's all I have. Hopefully you guys can help me out. I'm probably saying a million times, and I'm not really sure, like I said, how to go through besides just reading it from her writing, how she wrote it. So I just kind of did it in that order. It doesn't really seem 100% right, but that's what I have. I'm going to turn off the thing now.